Welcome to the TechPulse Healthcare podcast. It's week 9, I believe, or episode 9, and I've got my co-presenter Jonathan with us. How are you doing, Jonathan?
Good afternoon. Very well, thank you.
Excellent, excellent. Today we're joined by Ryan Aga. What makes him a bit different from our previous perhaps guest is that he's based in the US, in Minnesota. I think I heard correctly. And he's system director of clinical simulation at the HealthPartners is what I have you down for. But you can feel free to correct me as you introduce yourself. So over to you, Ryan.
Yeah, thanks, Atif and Jonathan for having me. I'm humbled to be a part of this crew and conversation. Yes, I am talking to you from Minnesota in the United States. So good morning to those that are visiting across the globe in Europe. Atif mentioned my title correctly. So I'm currently the system director of clinical simulation at HealthPartners. My main background is nursing, so I've spent close to 25 years as a nurse. And all of my nursing prior to coming into simulation was in emergency medicine. So I spent close to about 15 years in our level 1 pediatric and adult and burn trauma center in St. Paul, Minnesota, and that's where I spent the good chunk of my emergency medicine career. And always thought I was going to be a lifer in emergency medicine. I had done 10 years of leadership in emergency medicine in nursing, and thought I was going to be the director of emergency medicine, and the chief nurse officer didn't select me. So it was definitely an awkward time in my career because I thought, emergency medicine was my identity and my passion. But then it led me into this amazing, beautiful specialty of simulation and healthcare. And I've had the privilege and honor to be leading this incredible team for the last 5 years. The roots here at HealthPartners started really early in simulation and healthcare. And if you look at collectively, I still, attribute and say that simulation healthcare is still a baby. It's still an infant. It's 20 years old. And simulation here at HealthPartners has been really going since 2007. So some of the the godfathers and mothers of simulation we've been humbled and privileged to have here at HealthPartners, and are really supported vertically and horizontally across our system of having simulation embedded in our health system. So that's me in a little micro nugget. I've grown up in healthcare. My mom was a nurse. And so she kind of shepherded me to be a nurse. I would say my greatest strengths are I'm a relational person, connector. True through and through to me is compassion, empathy, and humility. And that's what I bring to the table. My wife is a nurse, and my brother and sister-in-law are physicians. So we're well entrenched in the narratives about healthcare previously, and then where we're headed in the future will be interesting.
Sorry, Artif, go on.
Go. All right. When you mention simulation, can you just explain what you mean by that? You mentioned the word simulation a few times in healthcare.
Yeah, great question, Atif. And I think that's to put it in context. And I always say simulation, the closest that you get to it, I talk a lot about, it's when you go to the airport. It's when you aboard an aircraft. And what simulation is it's experiential learning. It's developing objectives and then simulating out the real life experiences that healthcare providers are doing. And that can be from a patient in cardiac arrest and a bunch of teams converging and attempting to save that patient. It can be from human simulation, which is just this narrative here, humans, actors intersecting about How do I deliver bad news to a TIF that your significant other just passed away due to a catastrophic accident? Simulation brings you into a sphere where you work and you train interprofessionally, you train together. It's not passive learning, so it's not putting it on, a slide deck or, a self-learning module on a slide that I'm passing through. It's literally evoking this experience and bringing realism to that experience. So, and then we fail together, and then we debrief together about and critique each other, similar like the aviation industry did, and currently does do, of that we debrief together. You made this decision, Atif, with this protocol. Why did you do that? Good or nor bad? And having the ability to call that out in a safe, brave space and debriefing, that I don't have to worry about retaliation or retribution, that I just failed in sim because it's sim. It's not real. So we do a lot of that suspending reality, but we literally make these simulation experiences in healthcare come real in simulation. And without it, and there are many health systems across the globe that have literally no simulation experience or no simulation departments. What is happening? Us as patients, all of us are patients here and have accessed healthcare. Our clinicians are literally practicing on us as human beings. So in the aviation industry, the pilots that are flying your aircraft across the globe are spending twice the amount of time in simulation education than they are flying that aircraft when they're training. So in healthcare, it's minimal. And so without that and democratizing simulation in healthcare, all of us front-end users who are patients are being practiced on.
Yeah.
So it's a big gap within the healthcare industry. It's deeply rooted. It's happened for years. And what we're really on a mission is to, as we look at quality and safety in the United States, 250,000 people in the United States died to preventable medical harm. And we are doing nothing, really nothing with that number. So
Yeah.
go ahead. So go
No,
ahead.
just
Sorry.
explain what that is. You said something medical harm.
Yeah, so preventable medical harm is harm to patients. So, hey, say I'm doing a colonoscopy or an endoscopy, and I harm a patient. I perforate the esophagus, or I do something that creates harm to that patient. That's what's happening in healthcare, is that there's all of these safety mechanisms that put the patient at risk when they are a user of healthcare. And a piece of that is how we train all of us in the healthcare ecosystem. But a missing piece of that is simulation. And that's what aviation did. There was harms to people in the aircrafts, right? The passengers were being harmed. The pilots were crashing or aircraft were crashing, hence resulting in harm. And that's when the aviation industry started to look at how are we training, and they heavily adopted simulation. It's interesting to note, I think it's important, that one of the godfathers of healthcare simulation is Dr. Gaba out of Stanford in California. And Dr. Gaba was an anesthesiologist and saw all of the harms of patients in the operating room. And Dr. Gaba was also an aviator. So he blended aviation and healthcare as a physician and an aviator together and literally started to create simulation in healthcare.
And just one question before I hand over to Jonathan is around the technology you're using when you talk about simulation and things like that. Are we talking about VR technology? Are we talking about on computers or some other way? What do you guys use?
Yeah, let me give you what's in our tool bag, I'll say.
Yeah, same to
So
me.
as we create simulations, I'll go through around 4 of them that we pull out. One is behind Jonathan, there's the goggles. I see the Oculus headset or whatever, use VR or extended reality. So either VR or mixed reality. I think the new term is XR. That is emerging. We just signed a contract with a large vendor in the United States and globally to launch XR simulation at HealthPartners. So we'll be launching that Q3 and Q4 of this year. What has been embedded the early on years really was simulators, mannequins. So these mannequins literally can breathe, they can vomit, they can have heart sounds, they can have bowel sounds, they can do a lot of different anatomical manipulations with the mannequin, with vital signs projecting. They can talk, you can embed different voices. And so that's mannequin-based simulation. There's also task-based simulation. Say that there's, from a head up, and I want to practice my insertion of a central line. And I can do that over and over until I achieve competency with faculty in the room giving me insight and perspective. And so it isolates kind of that area anatomically of the body that I need to do procedures on. Chest tubes, for example. So when I put a chest tube in a patient, I can have a task trainer that I can put it in over and over and over to achieve competency. We also, like I mentioned before, have human simulation, and those are very high fidelity actors that can carry out and act out really realistic situations in healthcare. Workplace violence, for example, a problem that we've had horribly here in the United States. So a very violent actor, and how Jonathan as a nurse is going to deal with that and de-escalate that human actor. And then the other one that's emerging is immersive design and how to use simulation in the design methodology. And that goes for, designing a new space in the healthcare. That's put it through simulation to see if what works well, what doesn't work well before we build that space. The other piece
Wow.
is that we're using on protocols, policies, and work standards. Something that's been done well in the engineering industry is they always simulate. They always, before the product line goes out to the user, it's like gone through many iterations. We're missing that a lot in healthcare. We collaborate in, conference room spaces. We think we have the best practices and standards, and we don't co-create with the front line, who is an insurmountable, valuable tool because they have to use it, they have to deliver it. So we've been using simulation on protocols such as a sepsis protocol. Put it through simulation, put it through these things that I just mentioned to see what works well or what doesn't before it goes out to the front line. And if it doesn't work well, you know what's going to happen. They're going to have a
Mm.
workaround. The workaround will result in a safety event, and then the patient will be harmed. So really using simulation in a wide breadth of opportunities here as we continue to navigate the current and future of healthcare.
That's amazing that you're using it in design circles. That is really quite unusual, I'd say. And I'm a big fan of things like FMEA, failure modes effects analysis, where you try and break a process.
Yes.
You see what can possibly go wrong, and I can. It's fine doing that on paper, with your brain, but actually you then put it in a real environment and you apply human factors to it. I can imagine the richness of learning coming out of that exercise must be pretty extraordinary. And there isn't really anything that you couldn't test.
Right. Many people say that. They come to us and they're like, what can you simulate? I think really we can simulate anything and most everything. There's not
Yeah.
been a thing that doesn't come to us. So like we can put this through the methodology of simulation, of pre-briefing, doing the sim and debriefing. Yeah, it's very powerful. The power of simulation not only lies in what you mentioned, Jonathan, just best practices and in breaking the process. But it also evokes, I mentioned to a crew in Norway earlier this morning about using simulation to evoke joy, togetherness, working together through a complex problem, in a safe, brave space that I don't have to worry about an outcome. That's how we learn as human beings, and we need to do more of it. We've been thrusted and are isolated in the way we've trained in very passive environments. We've got to get gritty. We've got to get work together. And when that grittiness comes together and we fail together, that's where people are like, this is amazing. So, yeah.
On an economic level, Ryan, you may or may not be aware that the NHS in particular, is always struggling for money, and any time away from patients really has to be very thoroughly justified. How do you argue the economics behind your simulation? How do you get people released from the front line and make the case that this is time well spent?
Yeah, you've hit the nail on the head there, Jonathan, in our conversation. I think it's a challenge. I think it lies in advocacy. Each one of us need to be the advocates for ourselves, our profession, our specialty, and ourselves as patients. And that's a long game, right? That's like I mentioned, those deep roots of not getting time, funding, all of those things in training and education. Where do I take that? Where do I take this internal visceral feeling that we know it's the right thing? We know we need to do more of it, but where do I go with it? And so I think it's really important that we continue to amplify our voices, that we align to our societies that are pressing this forward. I'll just say, Jonathan, and it sounds like NHS is struggling. We equally in the United States are hugely suffering. I would say I test like having been in healthcare 25 years, we are pretty much near rock bottom. And what we are getting with our Medicaid, Medicare funding with our current administration is going to be even worse impact. And so then it just creates all of us that are continuing to be eternal optimists to carry this forward and use our societies to be that voice and to continue to amplify, but it's exhausting. I say the most power in all of this is through storytelling. And of course, either quantitative or qualitative data. Qualitative data and the ability to storytell is hugely impactful. And if you open simulation up to not just the health system, but it also go into the community, to broader networks, you then start to create a movement. And when you've got a human being in front of the ecosystem, the community, the academics, whatever, and they're able to share the story that they were saved through simulation and training, and that healthcare has got this horrible numbers, and we are going nowhere, and we need to engage them as a helping tool. They start to come around. And that movement just continues to evolve. And so it's really important that we, I would say, to kind of wrap it up, engage societies, keep your voice active, even though when you are exhausted, you keep going forward, and you bring it out of you broaden your network, and you literally bring in humans that have been affected, and they can tell the power in the story. So in our system, we're humbled and grateful to have an executive leadership team that believes in it. They've seen it, they've heard the outcomes. And we still have a lot of work to do, even in our system, particularly with physicians. We know they're the main portal to keep us funded. The more patients that they see, the more we're able to charge the dollar. But nursing has been definitely an early adopter, and it's probably our biggest user, but we have work to do with physicians. And I think we're all in this together.
Thank you, Ryan. And look into the future. You mentioned branching out into XR. I speak to people who give me the impression that XR presents a bit of an existential threat to in-person simulation. It sounds like you're embracing it and you're adding it to your toolbox rather than viewing it as a potential threat and replacement. Is that right?
You hit it spot on. Yes, you're correct. Yeah, and I think it is amongst all of us that are leading these movements. Humans are not going away. Humans will be central to existence, and so we need to take the human capital of what we are most needed for in time, to take off what we have been doing, all of it, right? And so to augment the power of technology, that I can literally take off some of that data analytics that I've had to do and go through spreadsheets and Excel documents and like line by line and create all that. I'm going to take that off, but I know what humans are most probably needed the most are compassion and empathy and listening and presence. And so I think to do that is central to all of the movements of not just XR, but AI, and all of it. We've got to keep the human capital central and where we are needed most, to leverage on us as humans is so important.
Do you do you guys capture you know in the effort, because this is industry wide really with simulation and XR and things like this, where it's tough to convince people. It's always quite uphill, and it's difficult to get momentum. Do you guys capture statistics around that? I know you mentioned 250,000 this happen. Is there any way you guys can measure or do measure that actually what you're doing, the simulation services, that they are helping to reduce that, or people are feeling more capable, or some sort of measure in that way?
Good question, Atif. Yes, so we measure all of our simulation programming. We've got a dashboard and a portal that we use our survey and evaluation research team at the HealthPartners Institute to be a part of, on a very thoughtful process, how to extrapolate data and show that. If you talk to Dr. Gaba at Stanford, it is very, very, very hard to show I mean, it's not super, super hard in my perspective to show the immense that literally in simulation, the power, and to see the wraparound or the return on investment. I would literally have to follow every sort of clinician out of the simulation experience to see the nuanced power of simulation. And so when you talk about data and ROI, and there's some really cool exemplars, I would say Dr. Barker at Jump Simulation in Chicago, she's done a tremendous analysis of using data to show the ROI and benefit. A good maybe person for a future podcast for you guys to hear about. But I'll just give you a quick example. We worked with our system-wide interpreter services team here at HealthPartners. Interpreters in the healthcare industry have really been seen as that literally from patient to provider and nurse to interpret what's going on and what they're saying. And they've been left out to speak up around safety. And if you think about an interpreter and they are seeing and hearing the whole perspective of the patient, they felt that were in this just one bi-directional tool to interpret the language. We measured them, and they had a really difficult time in their patient culture of survey data over close to 80 to 90 interpreters. They were missing the mark how to speak up for safety in the organization. So our team came in, we did immersive simulation with all 80 interpreters. And we moved their culture of safety data metric up by 10 points from 80 to 90. And 100% of those interpreters after the simulation and training said that they would speak up.
Wow.
So that is the power of simulation and experiential learning. Those are the data points that we latch onto and we show to our executive leadership, like this is what the people want. And it has the power to do amazing things. So that's just a small little sliver. And then back to Atif, the most powerful one, data point, is a live saved through simulation.
Absolutely.
And I have about 20 of them that I could speak to, that I could bring that person in, and they could say, and I've connected that point, that when the team did this simulation and infused rapid blood or products at a rapid amount of time and did it over and over and over, they saved my life. And there's nothing that probably any data point on a spreadsheet that can't overdo that outcome.
Yeah, that's what it's about, right? We're trying to make things safer, and saving lives is the ultimate. So
Yep.
it's really, really amazing. And in fact, you probably answered my next question was around just any cases that really wowed you, where you saw simulation take have such a big impact. But I suppose there's no bigger impact than that, which is really great. Lastly, then, where do you see things moving for yourselves or even your industry in there over the next kind of 5 years, 10 years, anything like that? How do you see things changing and moving?
I see things changing and moving very dynamically and with a bunch of the waves of healthcare as we reshape it and reform it. I will say I believe the newer generation is there's going to be non-negotiables, that simulation will be a non-negotiable. It's the way it needs to be. Every health system really across the world needs to democratize it, develop it, and implement it based on the outcomes that we are seeing with simulation in healthcare. I see it in the lane that I mentioned being a very at a integral part of design. Is simulation will need to be embedded there, not just in the educational lane, but also in the design and the quality side of things. And so I see it changing of just not be purely education, but also being in the design process. And then lastly, a call to action that simulationists need to be at the highest level of quality and patient safety in organizations. We can't be asynchronous. We have wonderfully motivated, very like people in safety and quality and in simulation, and that we need to be interconnected to what they're seeing and what we're delivering, and we need to be in a symbiotic relationship. And so really that call to action, I believe that was in the Journal of Simulation in Healthcare, of quality, safety, and simulation coming together now ASAP. So we can be a powerhouse as we see definitely more complexities in healthcare. People are going to be sicker. Care is going to change. They're not going to be accessing hospitals as much. Care is going to change into the homes. And we're going to have a tsunami of older people. So we're going to need to be very agile and moving simulation as healthcare is redeveloping and reshaping.
Right. Well, that's really interesting, and thanks for sharing that. I think we've come to the end of the road on our little interview with you. It's been really fascinating. You give each guest that we have on gives a different dimension, and you've kind of provided that as well. So it's really, really interesting. And thank you for your time and sharing your thoughts and experiences.